Well, thanks so much for that terrific description of your experience. I think we learned a lot, and I learned a lot from you along the way, I might say. So I'm going to be spending the next few minutes talking about caring for our colleagues. Let me move quickly through the CME required slides here. I have no disclosures. I will testify to that. So over the next few minutes, we're going to be talking about a number of things. We're going to be talking about what ails us, do a kind of review on how we think about the mental health of the healthcare workforce. We'll be talking a bit about barriers to seeking assistance, interventions that have been put in place to help the healthcare workforce, talk briefly about what's available at Hopkins, and then introduce a new program that was just launched this fall. So I don't know if this photograph looks familiar to anybody, but this is from a Life magazine spread in 1948 called The Country Doctor. And this is a fellow named Ernest Sirianni, who was a GP in rural Colorado. And this shows him leaning on his kitchen counter after a night of operating. And I remember seeing this years ago, and he seemed like a kind of heroic figure. I mean, tired, I suppose, but rock steady, really, clearly very committed, devoted to people, unflappable in some respect. Really, I think it was kind of a heroic image that stuck with me. And it seemed like a good sort of visual partner to some words that were written many years before that, and see if you can tell me who might have written these words. In the first place, in the physician or surgeon, no quality takes rank with imperturbability. Imperturbability means coolness and presence of mind under all circumstances, calmness amid storm, clearness of judgment in moments of grave peril. It's the quality most appreciated by the laity, and the physician who has the misfortune to be without it and who shows that he is flustered or flurried in ordinary emergencies loses rapidly the confidence of his patients. So the first essential is to have your nerves well in hand. Even under the most serious circumstances, the physician or surgeon who shows in his face the slightest alteration expressive of fear or anxiety has not his medullary centers. You can see, you might predict something about who this person was from the way he spelled centers there, under the highest control, and is liable to disaster at any moment. So any thoughts about who that might be? Right, there he is. So this is from the first address that's in a collection that I actually brought with me here called Equanimitas, of addresses that Osler made. And this was an address given at the time, it was basically his farewell to the University of Pennsylvania when he had decided to make the move from Penn to Hopkins and help found the Department of Medicine here. And I don't know how that quote strikes you, but I think we can agree that it kind of sets a high bar. We have to be imperturbable, right? I mean, does everybody agree with that? So bearing that image in mind, so fast forward many years. And these are images of physicians from the pandemic years. And I think it's fair to say that these are heroic images as well, but there's kind of a different message here. It shows physicians kind of as human beings, showing signs of vulnerability and showing signs that they're sort of at their limit in some ways. So, this was all characterized as a consequence of something that was called burnout. And I thought it was good to begin this conversation about what ails us with sort of a dive into this notion of burnout. And so I did a little research on this, and the burnout story is really the story of a couple people in a couple places. The first is this fellow named Herbert Freudenberger, and the place was the Haight-Ashbury Free Medical Clinic in San Francisco in the late 1960s. So interestingly, he was an NYU-based psychologist and analyst who decided to take a kind of sabbatical over the summer of 1968 at the Haight-Ashbury Free Clinic, which was the first of many such clinics that was founded in those days. And he was very idealistic at the time. He wanted to serve people, but he also was looking for personal fulfillment in some respect through working with these kids with whom he identified and sympathized. He had fled Europe just before the Holocaust and had certain ideas and feelings about the nature of the distress that these kids were feeling. So he was very affected by this, and he went back to New York and helped create something called St. Mark's Free Clinic in the East Village, where he spent every evening until 11, seeing the folks who came to this free clinic. And this was after having spent his entire day in his analytic practice elsewhere. So as you might imagine, he sort of ran out of gas at some point. After over a year of 16-hour days, he found himself exhausted, too tired to do things that might be enjoyable, and easily irritated. So he figured he needed to take a break. And so he took a break. And when he came back, he noticed that he wasn't the only person who'd been impacted like this with his work. He saw people around him who were exhausted, who were cynical, who were feeling that not very effective. And he thought this was kind of a syndrome that people in these so-called alternative institutions were exhibiting. And he called it burnout. And apparently the term staff burnout first appeared in the literature in the Journal of Social Issues in 1974 in a piece that he wrote. And this was his analysis. He said, this is a result of being overly dedicated to people who are, and this is a quote, in extreme need, and because of this, continually take, suck, demand, requiring continuous giving on our part. Now there's just a tad of hostility and anger in that, right? Directed against the people coming for care. But his prescription was self-awareness and self-care. We need to be aware that we're vulnerable to this, and we need to take care of ourselves. And he went on to write a fair amount about burnout, and including a mass market book that came out in the late 1970s called Burnout, How to Beat the High Cost of Success, which is in our library, I found, incidentally. Hadn't been checked out recently. So the second personality in the birth of Burnout, the origin story, is Christina Maslach. And the place was UC Berkeley. This is a photograph taken from the hill above the campus there. So she was a social psychologist trained at Stanford who was interested in how helping people, how therapists and social workers deal with the emotional impact of their clients and patients on their own mental health. And she had the idea that the ideal stance was something that she called detached concern. So you would care, but you wouldn't be sucked in a way that was detrimental to your own health. But that was often unattainable, she found, among her subjects, and replaced by a kind of defensive distancing in which they would lose concern for these people and treat them in a detached way and even dehumanized ways. And her subjects used the term burnout to describe this experience. And so she wrote about it in an article called Burned Out that appeared in a publication called Human Behavior in 1976. And her analysis is that while the causes of this were seen as situational, being overloaded, the suggested remedies really all had to do with people doing something about themselves, taking time away, taking time to do administrative work, the notion being that was less interpersonally demanding, may or may not be true. And she went on to write about it a fair amount, and also wrote a mass market book called Burnout, The Cost of Caring, that was published in the late 70s or early 80s. But being an academic psychologist, she also created a scale. And I won't go through it in detail, but it's worth saying a bit about what the domains were. There was a domain she called exhaustion, and I've listed the questions in that domain. I feel emotionally drained by my work. I feel like work is breaking me down. It stresses me too much to work in direct contact with people. So that was the exhaustion, emotional exhaustion domain. And then there was a domain she called depersonalization, and an example of a question from that domain was, I feel I look after certain patients as if they're objects. The third domain was called personal achievement, and asked people to say whether I look after my patients' problems very effectively. You would rate yourself based on how often you felt this way and how intense it was. And if you were burned out, your exhaustion score would be high, your depersonalization score would be high, and your personal achievement score would be low. So that was how this was scored. So over the decades that followed, there was a great deal of interest in this notion of burnout. It extended from the helping professions to the larger world of work, as you no doubt have seen. And it achieved a certain, I think, validation as an important thing when it made its way as an occupational phenomenon into the International Classification of Diseases in ICD-10, not as an illness, but as what they called a factor influencing health status or contact with health services. And it was conceptualized as resulting from chronic workplace stress that hadn't been successfully managed, and it was characterized by, guess what, 3 dimensions that should look familiar: feeling exhausted or depleted, feeling distanced from one's job or the people you're managing and working with, and reduced professional efficacy. So it's basically the same 3 domains from that Maslach burnout inventory. And it's important to, I guess, to be clear that it pertains, as far as ICD-10 is concerned, to the occupational context and shouldn't be applied to describe experiences in other areas of life, at least in terms of how the ICD-10 designation is concerned. So there was been an explosion of literature on burnout. This shows PubMed hits on burnout. By year, it shows there were in 1980 there were 27. By 2019 there were 2145. So huge explosion of interest in research on burnout in healthcare workers. And there have been quite a number of surveys and studies done. I'll just mention a couple here. One was published in eClinical Medicine in 2021, reflecting burnout during the pandemic. This was a survey of almost 21,000 U.S. healthcare workers from all over the place, about a 20% response rate, mostly female. And burnout was assessed using a single question validated against, guess what, the Maslach burnout inventory. And what they found was that burnout rates ranged between 39%, within healthcare, between 39% for folks who worked in IT and 60% for social workers, OTs, and speech therapists, with an average of around 49%. And you can see where physicians, residents, and fellows, nurses, and advanced practice providers fell out in terms of burnout, rates of burnout self. And what would emerge statistically from that is that there tended to be higher burnout rates among women than men. Then a little bit more recently, a Medscape survey looking at 9,100 physicians. Burnout was endorsed by 53% of them. Interestingly, top 3 causes cited were sort of administrative bureaucratic tasks, the work hours, a sense of lack of respect from other folks they were interacting with. And some of the people who were surveyed speculated that their own sense of burnout was perhaps influenced by their perfectionism or a tendency to be worry-prone or overly empathic. Burnout rates were highest in these specialties: emergency medicine, internal medicine, and pediatrics, where I think the volume of patients was so huge. It's somewhat lower in psychiatry. Kind of independent from that, depression was endorsed by about a quarter, and some proportion of those reported just cross-sectionally clinical depression, current clinical depression. And also significantly, about 22% endorsed that alcohol was a means of coping with their difficulty. So what about this burnout narrative? So burnout is really understood as a reaction to workplace demands that exceed the emotional capacity of the care provider. So it's reactive. Personality traits may influence vulnerability. That's kind of speculated. And treatment involves persuading people to rethink their role, maybe take time for self-care, sort of self-awareness and self-care. And for those of us trained in the perspectives mode of thinking, I mean, what is this mode of reasoning call to mind? I mean, it sounds like burnout could be understood as a species of demoralization, and sort of the life story perspective in action there. But there are other considerations also. Clearly, we saw that clinical depression is an issue in at least a subset of people with burnout and probably people without burnout. Maladaptive traits may contribute to the vulnerability to burnout, and substance use has been cited as one of the coping strategies, obviously a problem there. So burnout isn't clearly the only model required for us if we're going to be helping our colleagues. We need all the perspectives, and those of us in the room here who understand what I'm talking about will, I think, agree with that. So let's talk about briefly about some of these other perspectives and what light they may shed on the issue of clinical depression in physicians. We'll talk briefly about that. Substance misuse in physicians, personality traits as sources of vulnerability. So what about depression in physicians? There's certainly a number of studies out there. I'll just cite one. This was a survey of 5,000 physicians in Michigan, of whom over 1,100 responded. About 90% had lowish PHQ-9s up to 9, but 11% had PHQ-9s in the moderate to severe range. And those who had PHQ-9 scores in that range reported significantly greater distress, difficulty functioning, and poor productivity and satisfaction. And significantly, a lot of them avoided formal treatment, and almost a third of them self-prescribed antidepressants. The most worrisome consequence of a serious depression, of course, is suicide. And this is a really interesting story here that's kind of evolved. One of the earliest studies of this that I looked at was a meta-analysis of studies that looked mainly at cohort data from before 1980. And this study suggested that docs were at higher rates, risk of suicide. Both males, but particularly females, were at higher risk of suicide than the general population. So that's a meta-analysis published in 2004. Then a meta-analysis published in 2020 looked at cohorts that were, for the most part, studied after 1980. And in this meta-analysis of 9 studies, what they found was that the suicide mortality rate was actually lower among male physicians than it was among other men, but somewhat higher among female physicians than other women. And it looked as though when the data were looked at over a succession of years, that maybe rates for both men and women were declining over time. And then more recently, a study in JAMA Psychiatry that was not a meta-analysis, but was actually a retrospective cohort study looking at data from the National Violent Death Reporting System, suicide data from 2007 to 2018. So in that time, there were almost 160,000 suicides in the US among people 30 and older, including 2,300 nurses, almost 900 physicians. And what they found was that, at least in 2017, 2018, the suicide incidence rate for women in the general population was about 8.6 per 100,000. For female physicians was 10.1. For female nurses was 17.1. And that was a statistically significant difference. The difference between 8.6 and 10.1 was not significant. Among men, the rates were higher overall, but there was no difference in the rates for the general population for physicians or for nurses. So the conclusion of this study was that, adjusted for sex differences, the rate for nurses exceeded that in the general population, but the risk of suicide among physicians did not. And there are other data from other sources that seem to corroborate that idea. So what do we know about depression and suicidality among physicians? Well, we can say clinical depression is not rare among physicians, and it affects ability to practice, no surprise. And the suicide story seems to be evolving, but it appears that the current suicide rates don't exceed those of the general population. And I left out a slide showing occupational cohorts in which the rates are, in fact, much, much higher than they are among physicians. So what about substance use among physicians in the U.S.? the study that's often quoted first is a study of 9,600 physicians sampled back in the early 90s, about a 60% response rate. People were asked to report their use of 13 substances, and by far alcohol was the most frequently used substance. 10% reported daily use. Almost 10% endorsed having had at least 5 drinks at least once in a month. What they called minor opiates were used less commonly. It was unusual for people to use them daily. Benzodiazepines were also in use. A small minority used them regularly. In some cases, these were self-prescribed, incidentally. But as far as sort of as a way of summarizing it, alcohol seemed to be a problem when there was a problem most often, and about 8% of this cohort self-identified abuse and dependence over the course of their lifetimes. More recent study, sort of staying with the alcohol theme, was a study among surgeons. This was a survey that was conducted by the American College of Surgeons. A large study, 28% of the cohort responded. They assessed alcohol use disorder, the presence or absence of that, using the audit C. They also did burnout scale and depression scales and other things. And what they found was that 15.4% of the sample met criteria for abuse or dependence of alcohol, and the rates among, at least in this group, seemed to be higher for female than for male surgeons. And abuse or dependence was independently correlated with burnout, depression, and recent medical errors. I mean, and these were correlations. You couldn't identify which way the causal arrow pointed, but there were those correlations. There's very little written about dual diagnosis about physicians that I could find. The true prevalence really isn't known. But if you look at physicians in substance use disorder treatment, anxiety and depression are pretty common. One study found personality problems in a quarter, antisocial, avoidant, and or borderline traits in 25%. Delays in seeking treatment were kind of common. But the good news was that response to treatment was pretty good, especially in programs designed for docs, especially when treatment was mandated and their livelihood was on the line. So what can we say about substance use disorders? Well, we can say that alcohol is the most often misused substance, that there are other substances that are an issue as well, but seem to be less common. The good news, when treatment's pursued, the response tends to be good. Just a word about how enlightening the dimensional thinking might be. There's certainly a notion out there, and there's been literature on this, that docs tend toward compulsiveness, self-doubt, exaggerated sense of responsibility. But the data don't really clearly show that, and there's no empirical evidence of a specific physician personality. You know, neuroticism is a risk factor for burnout and depression, but it is in the general population as well. And conscientiousness seems to cut both ways. There's an increase of burnout among people who are highly conscientious, but also performance is better and there's less likelihood that people will drink. And extroversion may be protective, not surprisingly. So how do we think about what we're going to encounter if we're trying to care for our colleagues? Well, we need to be on the lookout for issues that come from all the perspectives. We need to be on the lookout for burnout, which is, we think, I would say, a species of demoralization. We need to think about mood disorders, especially about self-defeating and self-destructive behaviors like substance use problems, and at least consider the contribution of trait-based vulnerabilities. So, not surprisingly, all the perspectives matter. Okay, so barriers to seeking care. We heard a little bit about this from our patient. You know, there's stigma around seeking care for everybody, not just clinicians, not just physicians. It may be somewhat more intense because of the professional ideal of imperturbability, among other things. There's concern about confidentiality that will prevent people from seeking care sometimes. Difficulty finding the right source of care, or believing that they can be helped. I mean, I know as much as anybody does. How can this person I'm sitting here with, who doesn't really know the world I'm in, really help me? Fear of professional repercussions certainly are a barrier, and particularly fear of impact on licensure, which I wanted to spend a moment on here. Is it really an issue? Do docs really worry about that? Well, there was a Mayo Clinic study showing that 40% of docs reported they'd be reluctant to seek formal mental health care because of concerns about impact on licensure. And this is despite the fact that the Federation of State Medical Boards has been advising state boards to either not ask any questions about mental health or just stick to questions about current impairment, not about a history of illness or treatment. So these investigators back in 2017 asked the question, well, what are the boards and states actually doing? And so they got the initial and renewal applications from most of the boards around the country. And what they found was that only 42% were adherent to these recommendations to ask only about current impairment on initial applications, and only 44% were adherent on renewal applications, only a third adherent on both. So there was a big issue, and you could see why people might be concerned about that. Then there was a lot of advocacy for change in the years that followed from the Federation of State Medical Boards, from the Lorna Breen Heroes Foundation, that some of you may be familiar with, and from the AMA. And perhaps as a result of all this advocacy, things got better, and by late 2022, initial applications, for the most part, asked only about current impairment, and the majority of renewal applications asked only about current impairment. So lots of progress in a short time, but there's still need for improvement. Okay, now to turn briefly to programs to support healthcare professionals, what's out there. There are two kinds of programs. There are organization-wide interventions, and then there are what you might call programs to provide care for individuals seeking assistance. And what kinds of organizational interventions are out there? Well, some of them focus on aspects of the workplace, modifiable workplace stressors that might contribute to burnout, such as work overload or lack of autonomy or control. So these programs or interventions might seek to reduce hours of care, maybe reduce the length of rotations for folks who attending in academic settings, maybe give people more control of their schedule, those kinds of things. And then some offer programs that you might classify as seeking to fortify the workforce, and these are programs to promote physician well-being and resilience through things like exercise programs or mindfulness-based stress reduction. Don't have time to go into the details, but there is some limited research to suggest they're all helpful, but there's the interventions to modify the workplace tend to be the most helpful. Okay, so what do we have here? Historically, what do we have here? Well, we have a number of formal resources for staff and faculty. At the top of the list is the Employee Assistance Program, for which we engage an outside contractor. It's part of the employee benefit. Folks have up to 6 visits, and this is for all employees of the School of Medicine and the health system. So that's the Hopkins EAP. There's the University Health Service for trainees. There's the Department of Spiritual Care and Chaplaincy. And then there's the Office of Wellbeing, and I want to spend a moment on this because they've been so instrumental to creation of a program I'm about to talk about. And I think we've got at least one representative of that program here right now, Dr. Lee Biddison, who is pictured there. She's the Chief Wellness Officer for the system. Suzanne Brockman, who's the Senior Program Administrator for the Office of Wellbeing, and Carolyn Cumsty-Fowler, who is the Executive Director for Nursing Wellbeing. I think that's her title. There's not enough time to really talk about all that they do, but this slide here shows all of the different domains that they regard as important to any comprehensive approach to healthcare worker well-being. And a lot of the focus, I think, has been of our program here has been to cultivate a culture of connection and support and to enhance workplace efficiency. And I recently came upon podcasts that the Office of Wellbeing does, dealing with many of these issues or speaking to many of these issues, and they're terrific, and I would recommend everybody take a look at those. So there's also an informal program here, at Hopkins. So we talked about formal programs. So the informal program is really, it's the work of all of us in the department, but particularly there's something about the friendly face of Karen Swartz that has made people comfortable flagging her down in the hallway saying, I need some help, or I know somebody who needs help. And so she's been the conduit through which many people in the system have come to care over the years. During the pandemic, demand really soared and led to the creation of something called a COVID clinic within the department. But that was really, it was really still a kind of ad hoc, Karen. I think it's fairly, and it was, stuff still came to you and you found people to provide the care. I think that's basically what it was. So in the aftermath of the pandemic, we asked ourselves, can the department create a more formal response to our colleagues' call for assistance? So the idea of the Office of Clinician and Faculty Care was born. And it's taken a while, but it's designed by our department, championed by the Office of Wellbeing, approved this past spring. It's embedded within the Office of Wellbeing. It's under HR, supported by the School of Medicine and the health system. It's physically located in the 550 building. That's where its base of operations is. It features 2 tiers of care. Tier 1, it's a little bit EAP-like. It offers up to 6 sessions with a Hopkins mental health professional as part of the benefits package. More for short-term assistance and coaching, and then a second tier where there's team treatment provided by a Hopkins psychiatrist and a therapist to people who need further care. This is billed to insurance, and it requires partial subsidy from the health system and School of Medicine. Eligible staff initially includes physicians and other School of Medicine faculty, nurses, and APPs in Maryland, and we're hoping to be able to broaden the eligibility as capacity permits. The services can be in person or virtual. We're currently recruiting therapists, in case there are any therapists here. But we already have our docs, and Graham Redgrave and Dean McKinnon are already on the job. We have, the word is going to be gradually sent out throughout the system in a variety of ways. But there is a web presence. It's in the Office of Wellbeing website. If you go to this page, right beneath that banner, you scroll down, you see the Office of Clinician and Faculty Care right in the middle there, and this describes what is offered. Very excited to say the program has just launched in the last couple of weeks. Very quiet sort of launch because we're still staffing up. It's been years in gestation. It's had the effort of many midwives was required. The Department of Psychiatry, many people involved, and I won't enumerate the names, but you can see that it took a team from the department, a team from the Office of Wellbeing, several of whom I've already mentioned. We had Beth Thier from the EAP help us think this through. All of it wouldn't be possible without the sponsorship of Inez Stewart from the Senior VP for Human Resources, and of course the top leadership in the system. Everybody was really very supportive. And of course, there are others too numerous to name. So I've run out of time, maybe even a tad over. Very quickly, burnout's only part of the story. We talked about barriers to seeking care, and we focused on licensure issues and progress we're making there. We talked a bit about interventions, and we talked a bit about resources at Hopkins. And I opened with a quote from William Osler's first address in this volume called Equanimitas. So this is a quote from his last address in that book called The Master Word in Medicine, and this is what he said to his colleagues: "Yours is a higher and more sacred duty. Think not to light a light before men that they may see your good works. Contrariwise, you belong to the great army of quiet workers, physicians and priests, sisters and nurses all over the world, the members of which strive not, neither do they cry, nor are their voices heard in the streets, but to them is given the ministry of consolation in sorrow, need, and sickness." So Osler was good at setting a high bar, but he also was a master of words of inspiration. So with that, thanks very much.
That was really great, Bob. And thanks so much to you for your work in setting up this program that I think is going to really make a very very big difference around the institution. Let me see if folks have questions. You and I have had lots of chance to talk about this. Dr. Nestat.
Great talk, of course, fantastic, and it's great to hear that the hospital is sponsoring this. I think it's amazing to have access to the best psychiatrists in town for this. For burnout, it can be hard for people, especially not psychiatrists, to distinguish burnout from, as you said, kind of demoralization versus depression. Is the idea behind the new program with Graham and Dean that people would go once it's been determined that this is sort of a clinical depression, and then it might be a lower level of care for sort of run-of-the-mill burnout or demoralization? Or is the idea to go to them to help make that distinction? Where should we be advising faculty?
We should repeat the question. Essentially, the question is about whether the program is, how does the program handle burnout versus depression, and who decides?
So I think the expectation is that people will want to access their benefits covered service first. So I think the expectations of people will, for the most part, come in at tier 1, and where they'll be assessed, and it'll be determined whether are they people who maybe have a serious mood disorder and are clearly going to need ongoing treatment, in which case they may be moved to tier 2 at that point. Or does it seem like this is more of a situational issue, and with a little bit of coaching and reassurance, they might do well with a handful of visits. So I think it's going to be really in the hands of the folks doing the initial assessments to decide what the disposition ought to be. So.
Elsewhere, Dr. Gilbert.
Great talk. I was struck as you walked through the perspectives of this thing we sometimes come into with the life story perspective, because maybe a little bit more outward facing. Right? A lot of the research you went through was focused on particular vulnerabilities that you might see in a particular individual. But I wondered about the context in which these people are providing care, and whether some of the systemic things that we run into, say differences in gender promotion or that kind of thing, could be looked at as part of the problem, in which case it's less of an individual vulnerability and something more with the structure. And you talked about the things sort of shifting in terms of the institution. I'm curious if the research or the conversation in what you were reading to put this together seems to have shifted over time as well.
So I'll just repeat, should we be thinking about external factors, like institutional factors, that might be part of the issue as well as the person themselves?
So that question goes back to the origin story of the notion of burnout, because I think the initial assessment was that it was really a response to overwhelming demands or unreasonable demands, or demands that conflicted with your values. I mean, so it was precipitated by external issues. But the advice that people were given at the outset was that what you need to do is change yourself, and which seemed to be poorly aligned with the cause. And I think that was a concession to the reality that some of those external forces maybe were beyond people's control, and they needed to fortify themselves against them. But it's clear that the interventions that people I think most appreciate in terms of burnout reduction efforts are interventions that aim at making the workplace a better place to work, things that change the interpersonal environment and that eliminate some of those sources of distress. So I think it's, but when you're sitting with a patient individually, and this is where Graham and Dean will be, I think, challenged, and other folks challenged, to what extent are they, because in some cases they may be coaching people about how to deal with, maybe in very practical ways, with the stresses that they're under. And,
yes,
and Graham
yes. That leads us to what I think will have to be our final question. Dr. Redgrave.
It's actually a sort of a response to something, sort of an example of something that Sai sort of, this issue of when is demoralization about a person's individual vulnerabilities and when is it about the situation in which they work, and is there a role, for example, either in the Office of Well-Being or in the Office of Clinician and Faculty Care for kind of advocacy within the institution to change things that are potentially
comments, Dr. Roca?
Yeah, here, here.
Here. That was fascinating, and we'll look forward to seeing how this clinic evolves. Thanks, everybody, for coming.